So good morning. Now I'll talk about efficiency in total knee replacement and knee replacement using robotic technology. I started myself back in January, and I have to say it's been an exciting journey over the last 8 months. Started difficult at the beginning, and my goal was just to go through the procedure. As been said by faculty members, first 10 knees kind of learning the machine and the procedure, going through it, and then the next 10 actually getting comfortable, but then you have these data that you have to use. And then after the 20, I felt like, okay, I'm comfortable, and then I'm understanding things better, and I'm able to play with the tools better, and started becoming more efficient. My first total knee replacement was about 2.5 hours, and uni was about 1 hour and 45 minutes, and now I cut down my total to about 1 hour, and my uni is about the same as well, 1 hour. And this is just doing the cuts, and then I do cementing and implantation. So the whole procedure for me, about like 70 minutes max. So I'll just talk about tips and tricks that I learned over the last 8 months. So I just start my surgery with a standard routine for uni and total. I do my standard approach. I have my assistant on the other side. I use mid-vastus, but you could use whatever approach you like. Then I proceed with removing osteophytes. If I'm using a total, I remove both ACL, PCL, and PS guy. I do my medial lateral meniscus resection. While I'm working, my team doing the other part, basically my surgical, my scrub nurse is draping the screen and preparing all the flat markers and the trackers, everything's set. Once I've done my approach, if I'm still working on it, the scrub nurse can also calibrate the burr, so this way I'm not wasting time to calibrate. Once I've done my approach, pretty much I'm there to start the navigation part. So we make sure basically the screen is in. Once it's in place, docked in, we make sure the camera is nicely pointing to the area. And then I start with pins placement. So just like being shown yesterday with the pins placement, on the tibia I like to be 1 hand breadth below the tibia tubercle, so it's far away. When I put the twin peg, it's not going to come in the way. When I put the mushroom just to check my guide, it doesn't come in the way. And it's nice and easy. And not a lot of fractures. You don't see fractures in the tibia. It has more tolerance. The problem is in the femur. Over the last 8 months, I had 2 fractures, so I moved from the diaphysis. I moved completely into the metaphysis, and that solved it. I used the same technique as being showed by our colleague yesterday. He just tried to be in the metaphysis. I go with the 2 pins just outside the skin because I use a smaller incision. So my incision like about just 3 finger breadth above the patella and flexion, and just above the tibia tubercle. And so I just make 2 small incision and pass them medial lateral. Go for proximal cortex, just engage the lateral cortex, but don't go through it. And then this is the way I arrange my arrays, so they don't come in the way with the drapes and everything. So I like my tibia to be just kind of parallel with the tibia, but my femur, I like it at a right angle, so it doesn't come in the way throughout the whole surgery. Then I check that basically my trackers are showing nicely throughout range of motion. Then I start registering my tracker, femur. I don't use checkpoints on the tibia, and I think that's been great because these checkpoints, sometimes they move, especially if you have a porotic bone. So I just put the pointer on the tracker and move on. I like to register my medial lateral malleolus with an extension. This way the tibia tracker doesn't come in the way, and actually you're set for the next step. You see my assistant, he's putting both hands on the side. I don't like that. I like him to move the post up. I moved away from using leg holder for the reasons that we mentioned earlier on, the leg positioner, and I'm just using my side post and foot holder at 100 degree, 110 degrees, just said by Dr. Kappa, because that's most of the work going to be done at that range of motion. So once registration is done, so you see the assistant now is late. He's trying to move it up because you don't want that post to be in the way when you are registering your hip center. Start at about 30 degree of flexion of the hip and then go up. This way when you come in extension, you come nicely at the circle below. Don't start an extension and then you need to go below the table. So start at about 30 degree of flexion and then go in full flexion and just circle around. I like to be very close to the center point. Once that is done, then you register your natural position. It's important just to, as you can see here, my hand just on the right at the heel, and this way I keep in both the tibia and femur in contact. And make sure that the patella is pointing to the air, so just natural position without any stress. Then I take it through range of motion. I start in full extension. I start with valgus. Sorry, that's range of motion. You just take it through range of motion. Then the stress view. So initially I started using those Z instrument, and just like other speakers, the same experience. Medially it's fine, but laterally is a problem. It always slips out. And then if you're applying medially with the Z and laterally with hand, then you're using two different methods. So I just use my hands and just rely, just like I'm doing my stress after surgery without instruments. You're just going to check medial, lateral stress. So I usually start with full extension and valgus, and then start dialing into valgus stress, going through range of motion, up to 100, 120. You don't need to go through all flexion. 120 is max, so that's good. And then I reverse the process going back. So from that position that I flexed, I just reverse it and keep extending. You are fine at this position, but then I recommend to ask your assistant just to support the femur. That will help you to apply the valgus stress, because the post is out of the way at this point. So once that is done, you'll have a kind of a graph. You like conformity, just like, you know, you don't want outliers. You want smooth, kind of gradual curves going throughout range of motion. Once that is done, then I start mapping. So the way I do mapping, I go to the top. My assistant comes down. He holds the leg because he is set for flexing. All right? I have a Homan just at the lateral tibia plateau, retracting the patella out of the way. And I use a gill piece. As you can see here, this opens up medially. You could see things very nicely. So you don't have any assistant on the other side. You don't have any Homans coming medially. Everything is from lateral, because you need to have clearance on the femoral side. So I start at the trochlea, and actually you don't need to move very slowly. You go very fast, like brushing. So initially when I started, I was just going slowly, respecting the computer is slow. Actually, I was very slow. So you just go fast, just brush it like as fast as you can, and don't worry, the computer will register. And keep your eye on the femur. Don't put your eye on the screen, because this is where registration, garbage in, garbage out. So make sure you are registering exact points that you are seeing. So I start with the trochlea, and then I go laterally and just brushing, and then as I reach to the posterior, my assistant immediately just flexes. So I'm getting clearance to the posterior condyle, and I just keep brushing and make sure that the pointer is on bone, the tip of the pointer is on bone throughout the whole flexion. That's very big mistake is basically people looking at the screen and then they don't look at the pointer. The pointer is actually the metal is touching, but the pointer is outside the cortex. So just make sure that the cortex is all the time, and then your hand move from this position to actually this position. So the pointer is on cortex all the time. So once he's in that flexion, I don't ask him to extend. I just go, I take my foot off pedal and I go to the other side and I do exactly the same. Just start where I basically stopped anteriorly and just go quick posteriorly. And that's done. Once that's done, he brings it into the foot pedal, and I just register my anterior notch point, and I paint that completely. This way I see it clearly when so to avoid notching. Just one point I forgot to mention, my anterior notch point is the most anterolateral, because this is where you're going to notch. I don't take from center, I don't take from medial. So I take from the most lateral, where my exit point is going to be from the saw. So that's the model. You don't need to have a full model like this, but I mean, this is how I started initially, so I keep doing that. Actually, if you just move quickly, you get always nice model like this. So once that is done, I switch position with my assistant. My assistant go up, I go down, and I put the retractor, the same lateral retractor at the lateral plateau stay the same, and then he put another retractor medially. This way I'm getting all medial exposure. Okay? Or you can put it just at the PS and then sublux it anteriorly if you want. So register your center point, medial and lateral at the plateau, and register, then start mapping. So once you start mapping, you just go quick and fast. you don't need to be bogged on about going through the whole lateral cortex, because the sizing will be determined later on, and it's not a big deal. You just want to get the full coverage of most of the medial, most of the lateral. And then I mark my tibia plateau. This way I use it as a guide. Usually I use my transepicondylar or posterior condylar axis to the tibia, and then I use this as a secondary marker if I see things are off. So this is the screen that we kind of used to come to, and then we spend a lot of time on it. Don't spend a lot of time on this. Just focus on the top right corner and left bottom corner. So I focus, I don't know if the laser shows. So I just want to look at the sagittal, just make sure that I'm not notching. And then I go to the axial below, and then I want to make sure that I'm taking major resection, I'm full contact on both condyles posteriorly, if there is cartilage. However, if there is no cartilage medially, I need to build that up. A lot of the time you see that basically that we see this in Asian knees, where the medial femoral condyle posteriorly is just cortex. It's bone. There is no cartilage whatsoever. So if you use an posterior condylar axis and you dial in 3 degrees from that, then you know your external rotation actually probably 5 degrees. So I try to go to a 1 degree external rotation at this point, just 2 millimeter making up for cartilage. I don't use measurements, so don't go for the major caliber here just without caliber. Just make sure your medial lateral positioning and then your correct AP size. And then your rotation, just you want to make sure that it's as posterior as possible without notching. Then this one, you don't need to be bothered with measurements. Just make sure that the keel is centered, so you make a measurement. I always keep my posterior slope now at 3. Previously, I used to dial and play, but just keep it at 3 degrees and move on and to the next screen. So here, these two screens, you just jump over quickly. And then this is the screen that you need to spend time with. So here I bring the ruler and start measuring how much we are taking, just like you do your conventional knee. So I want to measure my distal femur first from the least affected side, lateral femoral condyle. If I'm using a journey, it's going to be a 7.5. And if it's a Genesis 2 or a lesion, it's going to be 9 millimeter. And then on the tibia, I would take 10 from the least affected side. And then check your flexion extension gap. And this is your workhorse. And then you go to the rotation. You can play with the rotation. So again, I wouldn't go into extremes. I would just stick with 0 tibia varus. On the femur, I like to dial 2 degree varus. And if things still tight, at this point, I could, if I'm happy with my rotation and the cartilage posteriorly is intact, and I have 1, here I will dial 3 degree, and that will correct my medial aspect. But if the posterior medial condyle is completely bone, I'm not going to dial more external rotation because I know that's perfect rotation, and I'm going to rely on my soft tissue release to address my tightness medially. On the tibia, I will not go, as Dr. Vadia said, more than 2 degrees varus, because the robot might add another 1 degree. So if you're taking like 4 degrees, then you end up 5 degrees on the tibia. So stick with maximum 2. I think that's wise. So I would accept an extension slight loosening. More wide opening on the lateral side and extension. I like about 2 to 3 millimeter. And then inflection, I like about 2 to 3 millimeters as well laterally and medially tight. I'm not going to be too worried about this, trying to make it nice rectangle at this point. I'll just carry on with my cuts. So next we move on. Once we're happy, we do distal femoral cut. You can see here, basically, I'm doing distal femoral cut with the 6.0 version. Keep your eye on the screen and just keep moving fast. Don't worry, it's safe. You're not going to cut anything because it's going to stop. I have an exposure at this point and just going fast. Actually, it takes 1 minute to do your distal femoral cut if you just keep your eye on the screen and just keep moving fast. And don't press hard, because if you press hard, the bear will stop and give you type 2 error. Just be smooth, irrigation, and just keep going fast. So once my distal femur is done, then I go my tibia. I use the twin pick. Make sure when you do the twin pick, make sure that they are going as far posterior as possible. And then I use actually with the polyethylene, the tip was given yesterday by Dr. Kappa, but I use this as well. Use an 11 millimeter poly. This way you are really down. You are not very close to the top, so it's going to toggle. You are in good bone. And you're going to be taking that medial plateau, which is really hard. You're taking that, so you're not down to spongy bone, which is very good. Because if you go into hard bone, you're so going to bevel up, and you need to refine that with the burr. So make sure they are deep, and then you can bring them from medial lateral. This way your patella tendon is not coming in the way, because you can bear that as well. So just to be safe. Once I have the twin pegs, just basically use that magnifying glass and then go through it just like been shown yesterday, or you can use the targeting device. It's quite easy actually to go through them, and just go to the full depth until you see white. Once you have really good plugs here, when you put the mushroom to do the cuts, actually it's very stable. So you put the twin peg, you bring the mushroom on, and then you check your cuts. I will not be like crazy going, it has to be 0, 0. If it's 0, 0, and my slope is good, I will just pin all 3 pins and go. But if I'm having problems, then I will do a provisional cut. So slightly up, don't bugged up with it. Don't take too much, that's the key. Just provisional cut when it's not stable, and you can always finish that with the bear at the end. Okay? So once that is done, then I go to the femur. I change my burr from cylindrical 5 to burr 2 millimeter, and I mark my rotation. Then you just put your conventional jig. So I put Genesis 2. I use Anthem, so I don't worry that there is no software available. I'm just using Genesis 2. I put Legion PS, because Legion PS is equivalent to Anthem. If you're an Anthem user in India, just use a Legion PS, because this has the same profile, AP, symmetrical posterior condyle. And then your cut, you use a Genesis 2 if you have, or a Legion if you have. You just mark those rotation, put the 4 cutting block, and perform all your 4 cuts. Then you do your PS housing cut, you do your posterior ossifies removal. I see always there is an overhang posteriorly, medially, that you need to remove it, and that actually is your release, that tightness, that red mark that you see posterior medially, inflection, and could affect also your extension. So once you release that, that helps a lot. So once that is done, then I go to the balancing. So I look at the graph. This is what I like. I don't like to be in the overlap below. I like to be at the 0 and above. Medially, I like about 1 to 2 millimeter throughout range of motion. And then inflection, I like slightly more opening laterally as we go in more flexion. So there is a learning curve. This is the case. Aaron took a picture once we finished all the bone cuts, and actually it was 52 minutes. So that's roughly, if you follow this, that's what you get your bone cuts with. So there is a learning curve, as being alluded. Start with easy cases. At least do 2 cases a week, because you want to get that flow. You want to get familiar with. You want also your staff to get familiar with. It's a teamwork. It's not like one-man show. You're doing everything. Everyone has an allocation. Everyone knows his job and duty, what he's doing. Your scrub nurse knows what he's doing. Your assistant knows when to move things. So to do that comfortably and efficiently, do 2 cases a week at the beginning, and then you get hang of it. And then once you get really comfortable with that, then start doing all cases robotically. I mean, this is what I started, and I really enjoy the experience now robotically, and also my team. Also, the circulating nurse used to hate it because they used to stay longer and then delay cases because cases takes longer at the beginning. But later on, things are really efficient and smooth. And speed comes with familiarity. So this is my recommendation. So then thanks a lot. And I like to open the platform for comments from our faculties and participants for questions as well. Thank you.